Hello and welcome to Clinical Society meeting. Today in the Clinical Society meeting, the first presentation is from Department of Otorhinolaryngology and the moderator is Professor Rajesh Kumar and Dr. Shiva. I request the moderator to initiate the first presentation.
Good morning, everyone. From Department of ENT, we have a very interesting case. So I invite Dr. Silky to start the case. Silky, please.
A common clinical presentation with an uncommon diagnosis. Today I am presenting a case of a 33-year-old female, bank employee by occupation, and she belonged to lower middle class of socioeconomic status. She is a Hindu by religion and a resident of Mirzapur in Uttar Pradesh. Her chief complaints were multiple swellings in neck for 1 year and fever for the last 6 months. In history of presenting illness, she had swelling in bilateral neck for 1 year, which was initially single and small in size, approximately 2 centimeters, and appeared on right upper side of the neck, which was incidentally noticed by the patient. Gradually, multiple swellings appeared on bilateral neck, largest of which was about 4 centimeters. There were no discharging sinuses or ulceration present. There was no pain, and there was no increment in size during meals. The fever was for last 6 months, which was intermittent in nature and persisted for around 2 to 3 days. The afebrile period of around 15 days in between was present. The temperature was recorded up to 100 degrees of Fahrenheit. There were no chills or rigor. There was no night sweats present. The fever was not associated with any joint pain or skin rash. There was no history of any otalgia, rhinorrhea, epistaxis, snoring, or any nasal obstruction. There was no hoarseness of voice, dyspnea, or dysphagia. There were no chest pain, cough, or hemoptysis. The patient did not complain of any abdominal pain, swelling, icterus, matmesis, melena, or any alteration in bowel habits. There were no history of convulsions, headache, or any weakness of limbs. There was no swelling in any other part of the body. There was no history of any unexplained weight loss, rapid or irregular heartbeat, excessive sweating. There was no history of excessive fatigue, constipation, dry skin, or any unexpected weight gain. In past history, the patient did not have any major medical ailment in the past. She was not a known case of diabetic mellitus, hypertension, tuberculosis, bronchial asthma, or epilepsy. She did not have history of contact with any patient of tuberculosis. There were no major surgeries in the past. She did not have any history of intrauterine device insertion or any history of dental extraction. Although the patient was started on anti-tubercular therapy by a local practitioner 1 month back, she had no symptomatic relief. The local practitioner started ATT without any tests for tuberculosis. In personal history, the patient is married, has a non-vegetarian diet, and there is no history of any alcohol or tobacco addiction. In family history, the parents are alive and in good health. She has 2 siblings, both are in good health. There is no history of any malignancy in family, no history of any kind of similar illness in the family members. So to summarize the history, a 33-year-old female patient presented in our ENT OPD with swelling in neck for the last 1 year. She initially noticed a single swelling in the right side of the neck, which was about 2 centimeters in size, and afterwards multiple swellings appeared on bilateral neck. There was intermittent fever for last 6 months, which persisted for 2 to 3 days, reaching up to 100 degrees Fahrenheit, and not accompanied by any chills or rigor. The afebrile period of around 15 days was present in between. There were no complaints of any night sweats, loss of appetite, significant weight loss, difficulty in breathing or swallowing, or any other systemic symptoms. On physical examination, in general examination, the patient was conscious, alert, cooperative, and oriented to time, place, and person. The pulse was 77 per minute. The rhythm was not regular, and the volume was normal. The blood pressure was 110 by 72 millimeter of mercury in right arm supine position. The respiratory rate was 15 per minute, and the temperature was afebrile, and the faces were normal. Her build was average, and there was no paler icterus, cyanosis, clubbing, edema present. The neck veins were not engorged. and there was no lymphadenopathy in any other parts of the body. On the respiratory system examination on inspection, the upper and lower respiratory tract was normal in examination. There was no scoliosis, kyphosis, drooping of shoulder, winging of scapula. There was no wheezing or stridor present. On palpation, there was no chest asymmetry or spinal deformity. On percussion, on auscultation, there was within normal limits. The central nervous system, cardiovascular system, and abdominal system were within normal limits. On the local examination, on examination of the neck, on inspection, we observed multiple swellings on both sides of the neck. On the right side, level 2 and level 5 were enlarged, and on the left side, level 2 and level 3 were enlarged. On the right side, level 2 lymph node was around 3 into 3 centimeter, and level 5 was 2 into 2 centimeter. On the left side, the level 2 lymph node was 4 into 2 centimeter, and level 3 was 3 into 3 centimeter. The surface was smooth, the margins were regular. There was no venous prominence, no scar mark, no discharging sinuses present. The swelling there was no swelling in the midline of the neck, and there were no visible pulsations above the swelling. On palpation, the temperature was normal, and the swellings were non-tender. Multiple lymph nodes were palpated on both sides of the neck. On the right side, in level 2B, the lymph node was 3 into 3 centimeter, single in count. The level 5 was 2 into 2 centimeter. On the left side, the level 2B lymph node was 4 into 2 centimeter. This was the largest lymph node. On the left, in level 3, the lymph node was 3 into 3 centimeters. The lymph nodes were globular, smooth on surface, and distinct margins were present. The lymph nodes were firm in consistency and were mobile in all the directions. And on pressing the chin against resistance, the swelling became prominent. And there was no skin fixity, no fluctuation, no pulsation. There was no impulse on coughing. The trachea was in midline, and the common carotid artery pulsations were normal. The thyroid gland was normally palpable. On auscultation, there was no bruit present. We did the related local and ear, nose, throat examination. We found that the scalp was within normal limits. The oral cavity, oropharynx, Waller's ring were normal. The nasal cavity on nasal endoscopy through our 0-degree endoscope, there was no mass, any turbinate hypertrophy was not seen. The septum was in midline. The nasopharynx on posterior rhinoscopy and examining it through our endoscope, the posterior choana, turbinates, opening of the eustachian tube, torus tuberis were normally visualized. No growth or ulceration was seen. The larynx on indirect laryngoscopy through fiber-optic laryngoscope, there was no growth, swelling, ulceration, or any redness or edema. All the structures were normally visualized. There was no swelling palpated in midline of the neck. There was no pre-auricular or post-auricular lymph nodes. The pinna, external auditory canal, and tympanic membrane were normally visualized. So, in differential diagnosis, in Indian scenario and taking in account the patient clinical features, tubercular lymphadenitis was our provisional diagnosis. Other differential diagnoses are lymphoproliferative diseases, that is Hodgkin's and non-Hodgkin's lymphoma, metastatic lymph nodes, actinomycosis, sarcoidosis, and histiocytosis. So to summarize all the differential diagnoses, cervical tuberculosis, also known as scrofula, mostly presents with painless matted multiple lymph nodes. In our case, the lymph nodes were discrete and there were no other systemic symptoms. In lymphoproliferative disease, that is Hodgkin's or non-Hodgkin's lymphoma, the lymph nodes are mostly rubbery in consistency. But in our case, the lymph nodes were firm, discrete, and there were no generalized lymphadenopathy present. In metastatic carcinoma, from upper digestive tract, lung, breast, colon, gastroesophageal area, pancreas, genitourinary tract can manifest as cervical lymphadenopathy. In our case, there was no systemic abnormality detected on examination. There was no weight loss. The lymph nodes were firm and there was no fixity to the skin. In actinomycosis, there is mostly a prior infection before actinomycosis. Infection occurs through disruption of mucosal membranes leading to suppuration and subsequent abscess formation with discharging sinuses. In our case, there was no prior history of trauma, any dental procedure, any intrauterine device insertion. There were no discharging sinuses or abscess present. In sarcoidosis, the most common involvement is of lung, then skin, eye, and lymph nodes. In our case, there was no respiratory system involvement. There was no generalized lymphadenopathy. The patient was a non-smoker. And the chest X-ray, in histiocytosis, there is mostly multi-system involvement with lungs, skin, nails, and generalized lymphadenopathy. In our case, the patient was a non-smoker. There were no respiratory problems, and there was no skin lesion. So to summarize what we do if a patient of neck swelling comes in our ENT OPD, a patient of acquired neck swelling. We do the related local examination, ear, nose, throat examination through our endoscope and laryngoscopes. Then we do the skin and thyroid examination. So if we find the primary tumor, we go for staging and treatment. And if we don't find the primary tumor and if the swelling is firm in consistency, we do a fine needle aspiration cytology. And if it comes positive, we start appropriate treatment. And if it comes negative, we go for biopsy. That can be incisional, excisional, or true cut. If the swelling is cystic in consistency, we go for ultrasound or ultrasound guided FNSE. And if it comes positive, we go for appropriate treatment. And if it comes negative, we do the biopsy. So we further proceeded with the investigations in our patient. All the blood investigations were within normal limits except for the erythrocytic sedimentation rate. The hemoglobin was 12.3 gram per DL, and the other blood investigations were within normal limits. The thyroid function tests were normal. The erythrocyte sedimentation rate was 40 mm per hour. The chest X-ray was within normal limits. Then we further proceeded with fine needle aspiration cytology. And I would like to welcome the Dr. Rahul from the Department of Pathology to describe the histopathological examination and immunohistochemistry examination in our case. Dr. Rahul.
Thank you, Dr. Silke, for giving me this opportunity. Good morning, everyone, respected sirs, dear colleagues and juniors. I am Dr. Rahul from JR3 Pathology Department. In this case, we receive FNA stent slides. In this smear, we saw reactive population of lymphoid cells admixed with histiocytes, occasional histiocytes showing empyropolosis. Here we see histiocyte engulfed plasma cells and lymphocytes. Overall, we saw reactive lymphoid hyperplasia, suggestive of Rosae-Dorfman disease. For confirmation, we do excisional biopsy. Section from section showed lymphoid tissue with partially preserved architecture. In this area, in this area, mass extension of sinuses filled with cells having high eosinophilic cytoplasm, most probably originate from histiocytic origin. Some of histiocyte in this slides, some of histiocytes show empyropolosis. In this figure, we saw RBC and plasma cells and lymphocytes engulfed by histiocytes. So I confirm the diagnosis, Rosae-Dorfman disease. For further confirmation, we do IHC. For IHC CD68 positivity shows by histiocytes. in this brownish area, we saw CD68 positivity. Hence, we confirm the diagnosis Rosae-Dorfman disease in this case. Now I hand over the mic to Dr. Silky.
So, as said by Dr. Rahul, we confirmed after histopathological examination and immunohistochemistry, our diagnosis of Rosae-Dorfman disease was confirmed. So, we started the patient accordingly on the appropriate treatment. Firstly, we examined the patient for any other systemic features involving skin, subcutaneous nodules, subcutaneous tissue, nasal cavity, liver, spleen, or lungs, or any other compressive symptoms from the lymph nodes. We took ophthalmological, orthopedic, and neurological consultation to rule out any other abnormality in eye, skeletal system, and intracranial involvement. Due to the rarity of Rosae-Dorfman disease, the clinical spectrum and treatment outcomes are not very well defined. About 1,000 cases have been described in literature till now. There is no US FDA approved treatment of Rosae-Dorfman disease, and the patients are treated with various therapeutic agents and modalities. Accordingly, we started our patient on oral corticosteroids, that is deflazacort, 60 mg per day for 1 month, and then we tapered the dose over next 1 month of time. The response was very good and the patient became asymptomatic in 2 months of treatment. Although taking in note that Rosae-Dorfman disease is a relapsing and remitting kind of disease, and with more than 70% of it being self-limiting, we advise the patient to keep keen observation for any other nodules in body or any other systemic symptoms. These are the images of the patients after 2 months of corticosteroid therapy. We can see the lymph nodes are have decreased in size, and the patient is feeling very good at this point of time. In discussion, Rosae-Dorfman disease is a histocytic disorder described in 1965 by Destormes for the first time, and later in 1969 by Rosae and Dorfman as sinus histiocytosis with massive lymphadenopathy. There are about 1,000 case descriptions in the medical literature till now. In our case, the patient was a 33-year-old female, whereas Rosae-Dorfman disease has a slight male preponderance. The male to female ratio is 1.4. Classical RDD presents with massive bilateral painless cervical lymphadenopathy with associated fever, loss of weight, and night sweats. Common extranodal sites of involvement include skin, nasal cavity, bone, orbital tissue, and central nervous system, predominantly the duodenal part. So to classify the Rosae-Dorfman disease, there are 3 forms, that is the sporadic, familial, and cutaneous. The sporadic form can present as the classical nodal form, that was our case. The other forms are extranodal. Those can be associated with neoplasia, that is leukemia and lymphoma, and can be associated with autoimmune disease, that is systemic lupus erythematosus, autoimmune hemolytic anemia, and human immunodeficiency virus. The others are familial and cutaneous forms. Due to the rarity of the Rosae-Dorfman disease, the clinical spectrum and treatment outcomes are not very well defined. Most of the patients have mobile non-tender bilateral cervical lymphadenopathy. The literature describes that 70% of the patients are in stable condition, 20% are self-limiting, and only 10% results in aggressive local or systemic disease. In a very small amount of patients, Rosae-Dorfman disease can prove to be fatal when massive enlarged lymph nodes with combination of mass formation and cellular infiltration start compressing on vital structures. Several forms of therapy have been described, including corticosteroids, chemotherapy, which can be combined with alkaloids, anthracyclines, antimetabolites, alkylating agents, interferon, antibiotics. Radiotherapy and partial or total surgical resection has also been indicated. There is a prevailing need of better treatment strategy for Rosae-Dorfman disease. Although maximum patients of Rosae-Dorfman disease are treated adequately by corticosteroids, about 30% of the patients have recurrence of the disease. Surgery is indicated only in symptomatic patients or in those with involvement of critical structures. It is often unnecessary to intervene until and unless airways are obstructed or some major organ is compressed. The course of Rosai-Dorfman disease is very unpredictable. Episodes of remission and exacerbations may occur for several years. In our case, after careful analysis of the biopsy specimen, a conservative approach was adopted with progressive reduction of the lymphadenopathy and other symptoms. Thank you.
Thank you, Shilpi. So it was really a nice presentation from Department of Otorhinolaryngology. And the differential diagnosis, like points favor and points against, that's very important because you discuss what were the points favoring and what were the points against. So basically, this diagnosis, which you have made a rare disease, this Rosai-Dorfman disease. So I want to ask from the any consultant from the pathology, if they are there, or a resident from the pathology, senior resident from the pathology, that the differential, like when they have seen the slides, they straightforward make the diagnosis of Rosai-Dorfman disease because it's a rare entity. So any differential with the slides, I think they should have kept the differential also. It will be better if the consultant speak.
Good morning, everyone. I'm Dr. Neeraj Namega. Actually, when we received FNAC slides, we saw the slides keeping in mind all the differential which have been mentioned because tuberculosis is very common. But in this condition, we did not find any granuloma, no atypical cell like we have seen previously some cases where in Hodgkin lymphoma also we find emperipolysis. But in this case, no atypical cell was seen. There was no RSL, no granuloma. Only what we saw was this presence of this numerous histiocytes showing emperipolysis and a reactive population of lymphoid cells. So we suggested this is a reactive lymphadenopathy with features suggestive of Rosai-Dorfman disease. And subsequently, when we received the biopsy, we saw similar features with massive sinus histiocytosis, no other feature, no granuloma, no necrosis, no any atypical cell. So we excluded all these findings. We saw only massive histiocytosis with emperipolysis. And then IHC was done. Because histiocytosis can be divided into different groups, benign, intermediate, and malignant category. We did not find any features of intermediate or malignant category like Langerhans cell histiocytosis or malignant cell. IHC was done, which showed only positivity for CD68 and S100. Other markers were negative. So based on these features, diagnosis of Rosai-Dorfman disease was made.
Okay, thank you, Dr. Neeraj. Now I request Professor S.K. Singh, sir. Sir, you can unmute yourself and ask your question.
Thank you, Abhishek. Just query and to update my knowledge, why such a high dose of Deflocart was used? That is 60 milligram, if I remember correctly, they have given. So what was the need of giving such a high dose as anti-inflammatory agent in this case?
The dose of Deflacort is 0.9 mg per kg, and we started the patient accordingly for the inflammatory diseases. And then we tapered the dose as the patient started responding. We started tapering the dose accordingly.
Yeah, but as anti-inflammatory, even the lower dose has been found to be effective in other conditions, even respiratory inflammatory conditions. So a smaller dose could have been tried to get the similar response. As we know, 70% are self-remitting. So that's a concern. And there is no approved treatment or therapy, and also the doses of steroid for treatment of this disease.
Over 1 year period for the patient, when she started having the symptoms, she was put on various therapeutic modalities. She was also put on steroids, low dose steroids. Previously, she was put on Deflacort also by some local practitioner. Then she was put on anti-tubercular therapy. So as she came in our ENT OPD, we saw her previous these prescriptions, and we accordingly we thought of putting.
Okay, so that's fine. That's fine.
Thank you, sir. I request Dr. Nityanand, you can unmute and ask your question.
Is basically sites are also seen.
Okay.
How do you?
Dr. Nityanand, you are not audible. Okay. Meanwhile, I request Dr. Abhishek Pathak. You can unmute and ask your question.
Thank you, Dr. Abhishek. Very beautiful presentation by Department of ENT. I mean, we must congratulate them, but there are few reservations and one small comment and few queries, right? Without any systemic features, obviously you discuss it in your slide, the differential of metastatic disease young patient should have probably been kept down. That's just a small comment. Obviously, it has its own reservations. And the other thing is, you told 70% of the patients remain stable, and then there are patients who change into the secondary forms, and they also, some patients, they develop into aggressive forms. And your literature survey, which you did, showed that there are some immunosuppressants in which patients are put on. So why didn't you, I mean, I obviously think, and I obviously agree that you must be keeping your patients on follow-up, but don't you think with the steroid and the recurrence rates and the secondary forms, you needed to put the patient on some immunosuppressants to limit their relapse or changing into the other forms that you described? Thank you.
Sir, as rheumatoid arthritis is a relapsing and remitting kind of disease, and we are investigating all the other kinds of treatment modalities. And if the patient comes again and with some symptoms, skin nodules, with the neck nodules or any other kind of symptoms, we will definitely try and collaborate with other departments and try and put the patient on some other form of treatment. Right now, the patient was symptomatically, and the clinical features were improved very much. So we thought of stopping the treatment at this point of time. Also, the disease is mostly self-limiting, and in various case reports and in the literature or in the various articles, we see that after some time of treatment with corticosteroids, most of the patients respond. If it will relapse, we have definitely thought of putting the patient on some other kind of treatment modality.
Thank you.
I request Professor Deepika Joshi, ma'am. Ma'am, you can unmute and give your comments.
Yeah, I just wanted to know, can we make this diagnosis clinically, or is it only supported by histopathology? Like if a patient is coming with multiple lymph nodes, so can we consider it as a possibility clinically? Before, of course, the histopathology was discussed very nicely. That's my query.
So, ma'am, definitely, we can put as I said previously, and all the literature says that it is a very rare disease. So, in our ENT OPD or any other kind of OPD, when a patient of neck swelling comes, we can think of histiocytosis, but we rarely go to this rhodoid-Hoffmann. With very less, I don't think, very less point of time, we pinpoint that it can be rhodoid-Hoffmann disease. The actual confirmation will be made by this histopathological and immunohistochemistry.
Okay, thank you.
Good morning, ma'am. In last roughly around 20 years of practice, I have seen only 2 cases. This is so rare. We are seeing almost 450 patients per day in our OPD. Only 2 cases in last 20 years.
I think, sir, we have to congratulate the Department of Pathology or the pathologist who has made this diagnosis, because it's a rare entity, and the diagnosis has been made by the pathology department. And
definitely.
Yes. There is one more question, I think, that's from Dr. Rani. What about the blood sugar at such high dose of steroid? Have you followed up this patient? Any change in blood sugar?
Followed the patient for blood sugar, and previously the patient was normal, and after that also the patient she did not came out of the normal values. It was
Yes, continue.
Never came out of the normal values, and now we have stopped the corticosteroids, and she is absolutely normal right now.
Okay. So thank you once again, and Professor Rajesh sir. It was really a good presentation from your department. Moving to the second presentation, it's from Department of Anaesthesiology, Division of Neuro-Anaesthesia, and the moderator is Dr. Sumit Sachan. I request the moderator to initiate the second presentation. Over to you.
Good morning, sir. Am I audible?
Yes, you're audible.
So we move on to our next presentation, which is from the Department of Anaesthesiology, a division of Neuro-Anaesthesiology. So this case has been done in the last month only. The case entitled A Rare Case of Cervical Aneurysmal Bone Cyst. We face a lot of anesthetic challenges in this case, and it will be presented by Dr. Gautam. Over to you, Dr. Gautam.
Thank you, sir. Good morning to everybody. I am Dr. Gautam from Department of Anaesthesiology. Today we are going to discuss about a rare case of cervical aneurysmal bone cyst and its anesthetic challenges. A 20-year-old male patient who is a college student studying commerce, is a resident of Varanasi, came with chief complaints of swelling behind the neck for the period of 6 months and pain over the swelling for the period of 6 months and restriction of neck movement for the past 6 months. Swelling behind the neck, which was gradual in onset and progressive in nature, and there is no associated weakness in bilateral upper and lower legs. The pain over the swelling, which was also gradual in onset and also progressive in nature, and there is no aggravating and relieving factor for the pain. There is a restriction of neck movements, which was also gradual and progressive, and there is progressively difficulty in bending forward and bending backward of the neck. There is no history of trauma to the neck, no history of headache, loss of consciousness, vomiting, blurring of vision, seizure episodes, chest pain, difficulty in breathing, and vertigo. In past medical history, no history of diabetes mellitus, hypertension, tuberculosis, bronchial asthma, COPD, ischemic heart disease, and thyroid disorder. Coming to the past surgical history, there is no previous surgery done for any cause. Coming to personal history, the patient is a vegetarian, non-alcoholic, non-tobacco chewer, non-smoker, normal bowel and bladder habits was there, and there is a history of snoring with apneic episodes of 5 to 6 seconds was present, and there is no history of somnolence or daytime sleepiness. Coming to family history, which is not significant. General physical examination, GCS, E4, V5, and M6. Vitals, pulse rate 83 per minute and blood pressure 126 by 84 millimeter of mercury, respiratory rate 15 per minute and temperature is 98 degree Fahrenheit. Pupils bilaterally normal in size and reacting to light. No pallor, ictus, pedal edema, cyanosis, clubbing, and lymphadenopathy. Weight is 95 kg, height is 155 centimeter, BMI is about 39.5, which is grade 2 obesity according to WHO classification. Coming to cardiovascular system, S1, S2 here, there is no added sounds or murmur. Apex beat felt at left fifth intercostal space, and respiratory system showed air entry are equal on both sides. There is no added sounds. Abdomen was soft, non-tender, no organomegaly. Normal bowel sounds has been heard. Coming to central nervous system and spine examination, high mental functions are normal. Cranial nerve shows no cranial nerve deficit, and sensory evaluation includes touch, pressure, pain, temperature, and vibration normal in all 4 quadrants. Motor examination, bulk and tone is normal, and there is power at 5 by 5 in all 4 limbs, and deep tendon reflexes and superficial reflexes are found to be normal. Coming to cervical spine examination, there is a hard swelling behind the hard swelling present in the posterior aspect of the neck between the occiput superiorly and C7 vertebral prominence inferiorly, which is approximately around 10 cross 8 centimeter, and it is a fixed swelling, and tenderness over the swelling was present, and skin over the swelling was also intact. Thoracic, lumbar, and sacral vertebrae is found to be normal. Coming to airway examination, mouth opening is 3 fingers, and modified Mallampatti grading is grade 2, and there is a restriction of neck movements in flexion and extension. And there is no artificial dentures or loose tooth present, and oral cavity is found to be normal. Coming to thyromental distance, which is about 6 centimeter for this patient. Usually thyromental distance should be more than 6.5 centimeter. When it is less than 6.5 centimeter or less than 6 centimeter, it poses difficulty in intubation. Coming to higher mental distance, which should also be more than 6 centimeter. And for our patient, it is about 5 centimeter only with neck neutral position. Neck circumference is about 45 centimeter for the patient, and it is more for that particular patient. Coming to the differential diagnosis, there may be benign neck swelling present. The swelling in the posterior aspect of the neck could be benign neck swelling, chondroblastoma, giant cell tumor, osteosarcoma, and bone cyst. And it may be neurofibroma or schwannoma may also be there. Coming to investigation, hemoglobin 12.7 gram per deciliter, leukocyte count.
Here, the differential diagnosis which you discussed, the case has been referred from which department?
Sir, neurosurgery, sir.
Surgery. So I think they can discuss the differential diagnosis which you have kept, the points in favoring and points against.
Sir. I'm giving over to Dr. Ajit, sir.
Okay. So you are not audible. Shashi, turn on the video.
Sir, actually, there has been some changes in the slides in the differential diagnosis.
Okay. So can we have the at this juncture the points taken from the neurosurgeon?
So the differential diagnosis that we had discussed.
Hello.
Yes. Yes, Dr. Nityanand, you are audible.
Am I audible?
Yes, you are audible.
This is basically a subcutaneous giant mass which is present behind the neck of the patient, young patient. So most of the times for this age group, the diagnosis will be of benign lesions, which may be originating from the muscle or the bone or the nerve fibers if we move that inside. So bone cyst and giant cell with tumors are those lesions which arise from basically bone, like the posterior aspect of the vertebral bones. Neurofibromas and schwannomas are from the nerve sheets, nerve fibers. Similarly, the chondroblastoma and osteosarcomas are the malignant lesions which arise from the bony tissue of the neck. So it's simple. There is nothing.
Any clinchers in the history and examination which are favoring the particular diagnosis?
See, it's mildly white tender, and the tenderness is because of the big lesion or size of the lesion. Otherwise, there is no other feature favoring any malignant changes. So the diagnosis primarily was benign mass originating from the bone, and it was most likely aneurysmal bone cyst.
Okay.
Right.
Right. Yes, continue.
Yes. Coming to investigation, hemoglobin is 12.7 gram per deciliter, total leukocyte counts is 9.3K, and platelet is 1.6 lakh, and LFT and RFT is found to be normal, and sodium 142 milliequivalents per liter, and potassium 4.2 milliequivalents per liter, and chlorine 102.30 milliequivalents per liter. Coming to investigation, chest X-ray. So chest X-ray PA view of the patient with adequate exposure, and costophrenic and cardiophrenic angles are not blunted, and there is no evidence of cardiomegaly, and bilateral lung fields are found to be normal, and trachea is in midline. Coming to this is the electrocardiogram of the patient, and this shows rate of around 85 to 86 per minute, and normal sinus rhythm, no axis deviation, no ST and T wave changes, and it's found to be normal. I request Dr. Priyam ma'am to discuss about investigations, radiological investigation. Welcome.
A very good morning to all the respected teachers, seniors and my colleagues. The investigation we have here is we have a CT scan here, axial sections. Here we can see a expansile lytic lesion, which has caused significant thinning of the bone, and it is involving the lamina and the spinous process of the C2 vertebra, and it is extending from C2 to C5 vertebral level. Here we have.
Yes, if it is possible, just zoom in the image. Zoom in the image. Yes.
This is that
Yeah.
lesion, that expansile lytic lesion, which I
Okay.
was discussing, where it is involving the lamina and the spinous process of the C2 vertebra. And this is a 3D reconstruction, 3D CT reconstruction, which is showing a well-defined lesion at C2 at the cervical vertebral level, as I described. And for the further characterization of the lesion, we did an MRI. In the MRI, we can see a well-defined lesion. This is these are the T2 images. We can see well-defined lesion, which shows multiple fluid levels. In this, the fluid levels signify multiple blood. This is a multiseptated lesion, like loculated lesions, which has fluid levels, which signify blood within these loculations. And this is the same T2 axial sections, which shows a very well-defined lesion, which shows multiple fluid levels involving the lamina and the spinous process of C2 vertebra. So I would like to keep the differential as aneurysmal bone cyst by seeing this MRI scan. Thank you.
Thank you, ma'am. Coming to the summary, a 20-year-old obese male patient with history of dull aching pain in the posterior aspect of the neck with restriction of neck movement for flexion and extension for the past 6 months without any sensory and motor involvement is a case of cervical aneurysmal bone cyst involving C2 to C5. Our diagnosis is cervical aneurysmal bone cyst involving C2 to C5, and the surgical plan is en bloc excision of aneurysmal bone cyst under prone position, and anesthetic plan is general anesthesia with armored endotracheal tube intubation with intermittent positive pressure ventilation. Patient is kept nil per oral for the solid foods for 8 hours and clear fluids for past 2 hours. The patient was pre-medicated with tablet ranitidine 150 mg at night and morning 6 a.m. with sip of water, and tablet metoclopramide 10 mg at night and morning 6 a.m. with sip of water. Followed by the patient received in operation theatre with cervical collar in situ, and all ASA monitors are attached along with bispectral index monitoring for detecting the awareness of the intraoperative awareness of the patient, and large bore intravenous line 18 gauge has been secured, and pre-oxygenation done with 100% oxygen for 3 minutes with tidal volume breath, and patient was again pre-medicated with injection midazolam 1 mg IV and injection fentanyl 100 microgram IV. Nasopharyngeal airway inserted into the right nostril with topical local anesthetic and topical decongestants. Induction with injection propofol 120 mg IV slowly given, followed by the bag and mask ventilation has been checked, followed with the muscle relaxant injection succinylcholine 150 mg IV given. Manual inline stabilization of the cervical spine acquired, and airway secured with 8 mm armored orotracheal tube with help of video laryngoscope. After airway has been confirmed by the appearance of end-tidal carbon dioxide, followed by the muscle relaxant injection vecuronium 7 mg IV was given. Arterial line is placed in the left radial artery after checking the patency of ulnar artery using modified Allen's test, and ultrasound-guided central venous line has been inserted in the right IJV. Prone position achieved with the help of Mayfield frame, and arms are kept by the side. Mechanical ventilation initiated with volume control ventilation with tidal volume 450 ml and respiratory rate 14 per minute and peak 6 cm of water with target end tidal carbon dioxide of less than 40 mm of mercury. This video shows the video laryngoscopic view of the glottis. The placement of armored orotracheal tube has been done with the help of video laryngoscope. And the video laryngoscopic view of the glottis shows it is about grade 2B of Cormack-Lehane grading. That means the posterior aspect of the vocal cord and arytenoids are only visible with the help of video laryngoscope. That is, the posterior part of the vocal cord and the arytenoids are only visible. This corresponds to grade 2B of Cormack-Lehane grading. And this image shows the conformation of the endotracheal tube with the help of auscultatory method. And this image shows the airway conformation with the help of end-tidal carbon dioxide. Pressure points were padded with the help of cotton roll with arm supports, and multimodal analgesia has been achieved, and general anesthesia was maintained during the surgery with oxygen and air with 50-50% with isoflurane inhalation anesthetic agent with vecuronium as a muscle relaxant. Intraoperative monitoring includes heart rate, electrocardiogram, invasive blood pressure, respiratory rate, temperature, bispectral index, urine output monitoring, EtCO2. ABG intraoperatively was found to be normal and within normal limits. And intraoperative events, there are 3 episodes of hypotension occurred intraoperatively. One during the prone positioning, which is about 76/50 mm of mercury, and 2 episodes during the resection of the lesion, which was about 80/48 mm of mercury, which was managed with the help of intravenous fluids. Total duration of the surgery was 3 hours, and intraoperative urine output was 500 ml, and total blood loss intraoperatively was about 900 ml, and intraoperative crystalloids given was 2500 ml. Now I request Dr. Ajit sir to discuss about surgical procedure. Welcome.
Thank you, Gautam. Good morning, respected faculty members. After the induction, patient was taken in prone position with a neck and slight flexion, and head was fixed with Mayfield 3-pin fixation system. A pre-op lateral film was taken to ensure the location of the lesion. The cyst was identified from originating from C2 lamina with extension from vertebral level C2 C5, which were abutting the posterior vertebral muscles. Here we see the C-arm lateral film, which expansile lytic lesion arising from the C2 lamina or spinous process. Bony mass had trabecular septations inside with cystic cavities filled with blood. Piecemeal debulking of cyst was done, followed by intralesional curettage. Spinous process and lamina of C2 were completely destroyed. Facet joints were intact, thus there was no need of fixation in the post-procedure. Post-procedure C-arm lateral view was taken to ensure adequate excision of the cyst. Biopsy was suggestive of aneurysmal bone cyst. Here we see the bony capsule with fibrous bone with collection of old blood, that is clotted blood. Thank you, sir.
Thank you, sir. In the postoperative period, reversal of the residual muscle blockade was done with the help of neostigmine and injection glycopyrrolate, and trachea extubated after the patient met adequate extubation criteria. Patient was shifted to the postoperative cannules with nasopharyngeal airway in situ, and postoperative vitals was GCS, E4B5M6, heart rate 100 per minute, blood pressure 116/78 mm of mercury, SpO2 was 100 with 40% FiO2. Patient was shifted to ward with cervical collar in situ. CT scan done on first postoperative day shows no residual lesion, and patient discharged on the 7th postoperative day with stable vitals. Now I request Dr. Sumit Sachan sir to discuss about discussion.
Thank you, Dr. Gautam. Now, coming to the discussion part, aneurysmal bone cysts, these are the benign, proliferative, highly vascular osseous lesions comprising of blood-filled cavities. These lesions are locally destructive and weakens bones to the point of pathological fractures. The aneurysmal bone cyst was first described by Jaffe and Lichtenstein in 1942. The annual incidence of aneurysmal bone cyst is as low as 0.14 per 1 lakh of the population, and only 12 to 30% of the lesions involve the spine. In spines, mainly these lesions occurs in the lumbar, followed by the thoracic spines. And however, cervical spine aneurysmal bone cyst occurs only in 2% of the total cases. In spine, mainly the posterior column was involved, including spinous processes, lamina, and the pedicles. Most of these patients presents with the symptoms of ill-defined pain, stiffness, and swelling, which was also present in our patients. And it takes almost a year for definitive diagnosis of these tumors. Now, the exact etiology why these aneurysmal bone cyst forms is unknown. However, there has been 3 theories has been postulated.
Dr. Sachan, sorry to interrupt you here. I think this presentation needs to be emphasized in terms of the anesthesia.
Sir, I'm just coming on these points.
Because
so
the time is limited. Yeah. Time is limited. That's why. What are the special precautions you have to take in such an obese patient and regarding the case itself?
So these are the treatment option. The gold standard is the surgical intervention. We have done en bloc excision in this patient. Now, why we have taken this case for the CSM? Because of the anticipated anesthetic challenges that we had in this case. It is because of our patient was obese, having a BMI of around 40. Patient was having large neck mass. He is having restricted neck movements in the flexion as well as in extension. So because of these regions, the oral axis, the pharyngeal and the laryngeal axis cannot be aligned because it can only be aligned during extension position. However, after induction of the anesthesia, we could have extended the neck, but there was risk of pathological fractures. So that was also limited. Also, there was increased in the neck circumferences, which limited the intubation as well as the laryngoscopy in this patient. Now, these are the American Society of Anaesthesiology practice guidelines. This has been published in January this year only. They have shown that if there is any suspected laryngoscopy or difficulty in ventilation in face mask or supraglottic airway, then the ideal choice is intubation attempt with the patient awake. However, our patient was non-cooperative and gave negative consent. So we chooses intubation attempt after induction of general anesthesia using video laryngoscopy. And we were succeeded in our first attempt only. Now, after the securing of the airway, these are the another complication that can develop in any cases in prone position. Some of them are conjunctival chemosis, brachial plexus injuries, which occurs because of the malpositioning during surgeries. And these are list of the another complications that can happen during spinal surgeries in prone position. Some of them are hypotension in prone positions. Cardiac arrest has been noted, post of vision loss, and accidental extubation. So as an anesthesiologist, we should be able to deal with the devastating complications such as accidental extubation and cardiac arrest as well. So in accidental extubation, rather than securing the airway, we should better concentrate on oxygenating the patient, because the patient is in three pins, and it has been seen that putting the supraglottic devices in second attempts can cause a success rate of almost 95% in this. So we should go for the supraglottic airway devices. Similarly, what happens if the cardiac arrest occurs in this patient? So the cervical spine is probably open. So we should put a pressure on the shoulder joints, and defib can be placed in the infraaxillary regions to give any shock. So this case gave a take-home message of cervical aneurysmal bone cysts. These are the rare tumor posing anticipated difficult airways owing to its location and risk of pathological fractures. Obesity with neck mass further aggravates difficulties in oxygenation, ventilation, and securing airway. Prone positioning required during spinal surgeries is associated with certain devastating complications. Risk of intra-op hemorrhage may pose hemodynamic instability in such vascular lesions. Pre-op assessment and preparation is needed to manage such anticipated difficult airways, and multidisciplinary and interdepartmental team approach is the necessary to optimize outcomes.
So thank you, Dr. Sachan. It was really a good presentation. Basically, for this patient, what are the causes? The patient had 3 episodes of hypotension. So what are the causes, probable cause?
Sir, it has been known that while we turn the patient to the from supine position to the prone position, there has been increase in the abdominal pressure. There has been pressure in the chest that decreases the venous return. So that could be the one cause of hypotension. Now, second lesion during curettage, if there is ongoing bleeding, then it can cause hypotension during the surgical resection.
Okay.
So usually in such cases, we have usually we'll talk to the surgeons regarding the pre-op conditions, regarding the intra-op duration and suspected hemorrhages. So, and then accordingly we'll proceed.
Okay. And there is one more question from Dr. Anand, that what special precautions taken during anesthesia for such obese patient with history of sleep apnea? I think you already told. Any points you want to add further?
Sir, other than this, we can go for the sleep studies pre-operatively, in which we calculate the apneic episodes, and definitely a proper assessment, like we have measured in this patient thyromental distance, hyomental distances, mandibular protrusion, upper lip bite test. These are the airway indices that has been well described in recent guidelines, DAS guidelines, like Difficult Airway Society guidelines and ASA guidelines. So we'll have to take care of all these precautions. Also, in obese patients with neck extension, we can go for RAM position. RAM position makes the oral, the laryngeal and the pharyngeal axis in line, so which makes an intubation easy. We are doing it routinely in morbid obese patients, which are posted for normal surgeries like other than neurosurgeries.
Okay. Dr. Anand, you can unmute if you want to ask anything further.
Yeah, thank you. I just think there is one slide which is showing the investigation. The urea creatine value was 90 by 1.28, and it is, I think, abnormal from the anesthesia point of view. And I just want to know whether there is any correlation between these aneurysmal bone cyst and a patient is having obesity. Do you think there is any correlation? Have you obtained the clearance from the endocrinology? Because the BMI was 40, I think.
Sir, actually, as far as the literature is concerned, there has been no correlation between the obesity as well as the aneurysmal bone cyst. And normally, what the literature says, most of the aneurysmal bone cyst has been detected in early age groups. Almost 90% of these total aneurysm has been detected in within second decade of tumors. Most of the literature that says detection of aneurysmal bone cyst within 15 years or so. So it is unlikely that there is any endocrinology association with these aneurysmal bone cysts.
Okay,
however,
yeah. So I think Dr. Anand rightly pointed out that urea and creatinine value is abnormal, and that is not like.
Yeah, urea is definitely not, abnormal in this patient. However, as far as the creatinine is concerned, the patient is obese, having a large neck mass. So we have considered this also.
I think if you calculate the eGFR, it will come lower down.
Maybe, sir.
Okay. I request Honorable Dean Research, Professor Ashok Chaudhary, sir. Sir, please unmute and give your comments on this presentation also and the first presentation also, and you can ask question also.
Okay, good morning. So nice presentation. So in this case, I may query, what is the optimal oxygen levels you maintain during surgery? Because intraoperatively PO2 was 160 and you said it's normal. As a neonatologist, I am uncomfortable with this idea. So what is the optimal PO2 levels during intraoperative period? What are the guidelines say?
So first thing I just want to clear that the ABG that was done, it was done intraoperatively only with a FiO2 of 50. We have given 50:50 oxygen is to air combination in this patient. So the FiO2 here was approximately 60%, and the FiO2 by PO2 ratio is kept around 1:3. So there is no as such guidelines. What we usually do in obese patients, we'll do pre-op ABGs to assess the pre-op oxygen levels. We'll try to maintain maybe twice or three times the baseline values, and we'll parallelly do the post-op ABGs also in these patients. That's how.
So any risk of oxygen toxicity if you go beyond 90 to 100 millimeter of mercury PO2 levels? And are there any guidelines? I'm sure there must be guidelines in adult patients regarding PO2 levels.
Sir, as far as the guidelines is concerned, we'll have to keep a PO2 by FiO2 levels more than 2:1. Sir, they have not mentioned because these surgeries usually take a relatively longer duration of time, neurosurgeries. So, and ideally in all cases, we'll usually give 50% of oxygen with air or nitrous oxide, wherever it is needed. As far as the guidelines is concerned, there has not been any guidelines.
Okay.
Sir, to the best of my knowledge.
Thank you.
I request Honorable Dean of Faculty of Medicine, Professor S.K. Singh, sir. Sir, final comments from your side.
Yeah, both the cases were quite interesting. The first one, a rare case and nicely managed. I think we should be very much aware that we do come across rare cases, and the common presentation of rare cases will always be remembered. Pathology department has done very good job in identifying that particular case. The second case by anesthesia, I think this is another, though we do not have that much knowledge of problems during anesthesia as faced by anesthetist, but still that case was very nicely discussed and presented. So congratulations to both of the presenters, ENT as well as anesthesia department.
Thank you, sir. So thank you everybody for joining this clinical society meeting. See you at the next meeting.
Sir. Next,